Welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
The team at the Research Works podcast acknowledges the traditional custodians of the land and waters on which we live and work. We pay our respects to all First Nations peoples, elders past and present, and would like to acknowledge the traditional custodians of the land on which we record this podcast each week, the Whadjuk people of the Noongar Nation. We recognise their continued connection to this beautiful budja we call home.
Well, welcome back to another episode of the Research Works podcast. And once again, welcome back, Marissa. Thank you for co-hosting again.
Thank you for having me. It's good to be back today. And I'm pretty excited because we're talking about something today that's familiar to us, but in a different paediatric population.
Yeah, this is going to be really good. And I love how this has all been teed up, actually. We have someone in the studio today who's just finished her PhD and is here having a holiday in Australia, telling us all about the things I've never done in my own state before. So welcome, Dr. Elena Mitteregger. Did I do it right?
Perfect.
I do this all the time. Do you want to say your surname again properly for everyone else to hear?
Elena Mitteregger.
Oh, see, I don't think I said that right. But you're from the University Children's Hospital Zurich in Switzerland. So welcome to Australia, and sorry about this heat wave that we are experiencing right now. But it's quite different, isn't it?
Yeah, but you have got air conditioning, what we don't have so much in
That is true. And then you can go jump in the beach later.
Exactly.
On this 42 degrees Celsius day.
I think it's going to be 43.
Oh, my goodness. Yes.
Yes, and I love how you said Celsius. I keep forgetting to say Celsius to people who live in the US, and they look at me and go, it's not that hot. Come on.
I don't know what that is in Fahrenheit, but it's very hot.
It's above 100, I think. Yeah. Significant.
Look, for our listeners, before we delve more into Elena's area, I want you to tell you a bit more about her. Elena Mitteregger is a senior paediatric physiotherapist specialised in early interventions. She's currently working in the University's Children's Hospital in Zurich, Switzerland. Besides having more than 20 years of clinical experience, Elena recently finished her PhD titled EMI-Heart, a family-centred early motor intervention in infants with complex congenital heart disease. Elena is passionate about working with children and their families, teaching and translating evidence-based paediatric physiotherapy in practice.
It's pretty cool. I love that we have a fellow paediatric physiotherapist here and specialising in an area that we haven't really delved into, which I guess tends to happen a lot when you're in a hospital setting. But I love that you've done your PhD in this space and you've published it, and it's about an area that's so unknown. But congratulations, I suppose, is what I should say. After a PhD, it's quite the life, isn't it?
It is. Especially now being in Australia is really the best ever.
Oh, that's good. Well, that's the reward after you finish a PhD.
Yes, have a holiday.
Have a holiday.
Well-earned holiday.
Yeah, I think so.
I'm really excited to delve into this today, but as usual, we have an icebreaker question where we go a bit off track. And today is, what is your best scar story?
Okay. So I always wanted to try out driving a Vespa motorbike.
Oh.
But I wasn't allowed then. It was before I did my driving license. But I got my cousin on board, who was younger than me, and he said, I'm going to show you. But my aunt and, they didn't allow me so. So, okay, he put me on that Vespa, and I went off, but I didn't know how to brake.
Oh, no.
Oh, dear.
So the measure, in the end, it was all a safe environment, so that was fine. So it was not on the street, but the engine stopped. So that was my chance to brake. But unfortunately, I was close to a fence and hit my shoulder. So I have a scar above my shoulder.
From the fence?
From the fence.
Oh my goodness.
And I still remember that I went in the house to my aunt and she said, how are you doing, Elena? You look pretty white. And I said, fine. And then I fainted.
Have you been on a Vespa since?
Yes, I did. I did then a driving license for that.
Oh, good, yes.
But
we strongly advocate for that to all listeners.
Yes. Good.
That is a great story. That's a good one. So now, you can always tell so many people about that. Okay, so my scar story is something that happened relatively recently, and it was just so silly. So I go running quite often. It's how I clear my mind, and I go pretty much on the same track nearly every day. And then one day, as I was jogging along this pathway, I trip and I fall flat to the point where I remember just seeing the concrete. My hands were above my head, flat, and I rolled over, and I was like, "What happened?" Because I never trip.
Oh, no.
But for the first time, I saw that there was just a slight raise in the pathway, and I thought, well, that's definitely new. Anyway, where I actually really grazed myself was right on my kneecaps, but I didn't realize at the time because I was wearing leggings, kept going, didn't realize it was really bad, come home, go into the shower. Oh my goodness, it was very painful. But because it was on both of my kneecaps, I couldn't flex my knees when walking because it would scar, and then I would start walking and it would break all again. So I was here within our clinic and I couldn't bend my knees, and all the families were going, "What are you doing?" Because I was on my toes, just running along with my knees straight. And I'm like, I just can't break the scar again. But because I kept breaking the scar over and over again, or the scab, I do have 2 decent scars on my knees.
Even getting in and out the car, all those things.
It was very difficult. It was very difficult. And anyway, a week later when I went to the same place, I noticed that they had covered up the gap and where that was. And I looked at the house and there was a security camera there. So they must have seen me fall.
But how good they followed it up?
They followed it up. So I walk by now and I just wave knowing the camera sees me. But I've got 2 nice scars as a result of it. So always watch where you're running.
Absolutely. Well, you're in your zone, so it's fair enough.
Zone, yeah.
Mine is also my knees.
Oh,
so
okay.
I love basketball, and about 10 years ago was playing in a semi-final, super excited, trying to drive up to the ring, and got quite a heavy knock from a lady a bit bigger than myself, and tore my ACL and then had a knee reconstruction. And so I still have that smiley face scar on my knee. Very grateful for a good recovery in the end. But yes, that would be my we call it my smiley face scar.
It's a nice one. If it's going to be a scar, it might as well be smiley face. Yeah. And any more basketball?
No, I went back and then tore my meniscus. So, no, I'm retiring.
Good call. Okay, good call. Well, now that you all know our scar story, let's get into this actual paper now, and the series of papers that we'll be talking about today. So children that undergo open heart surgery within the first 6 months of life experience significant challenges. And for parents, the concern may be centred around their child's motor development, psychological and physical strain, and communication difficulties with healthcare professionals. For children, whilst it is understood that early intervention may improve motor development, there is still limited clear evidence. As clinicians, what can we do that is evidence-based to support this group of children and their families?
Elena, I was so inspired reading your papers and your qualitative study as well.
Great.
Just the fact that what you do pulls together so many things. And it wasn't just about the physical element and the physical therapy. It was about the attachment for families. It was about supporting families during critical time. And so, just well done on a fantastic paper. So I'm really excited to jump into that today. But like always at the start, we want to start with some of the foundations and kind of giving our listeners an understanding of what it is we're talking about. So let's start with congenital heart disease and open heart surgery for children. Can you tell us a little bit about what typically happens, when it might get picked up, symptoms, and what might be done?
It depends on the time of diagnosis. It can be prenatal, it can be postnatal, and also later. And depending on the severity of the diagnosis, they have to undergo open heart surgery soon after birth, or days after birth, weeks and months.
Wow.
Yes, and it is 1/3 of the children who require open heart surgery, and they are considered as the complex CHD children. So CHD is congenital heart disease.
Yeah.
Wow. And what are some of the symptoms that these children, if they aren't picked up, say, prenatally or early in postnatal period, what are some of the symptoms?
So you realize that many of them, they have delayed motor development, or they don't tolerate being in prone position. They spend a lot of time in supine or have difficulties in endurance, like positions, tired, sleeping, or sweat a lot.
Wow, okay. And I guess as you were saying that, there are quite, motor-based symptoms that you might notice. And do they get picked up as well because they haven't reached their milestones, as they're going along? Or, What prompts them to then go get checked out?
There's this obviously lacking of awareness that these children have profound difficulties for later development, is because it is attributed to the heart.
Yeah.
It is attributed to the intensive care unit, the surgery, and then to, just going to be fine. As soon as the heart has been fixed, everything's going to be fine.
Yeah.
So this is, the way that, it hasn't been looked at that so much.
Yeah. And I imagine there's so much there for parents to have to navigate through, because there's the thought of having to have surgery to fix something that would occupy a lot of their thinking as well, wouldn't it? Because it's not every day that you would have to go into hospital and have open heart surgery.
No, it's I think a very traumatic traumatic step in the life of the parents, absolutely. Because they don't know if the child is going to survive. So they really fear of losing their child. And the surgery takes hours. Yeah. And I think one of the things we always also miss or forget is that they have got a scar that marks their child for their life. Yeah. And I think I told you that before, that it made me think a lot when parents told me that they took a picture of the infants unmarked before surgery. Wow. So to have a child which is perfect, or how do you say that? Yeah. So that was pretty impressive when I thought about that.
It must be such a huge thing, particularly when children when they're picked up prenatally. And I guess the parents then walked through that before having the baby, what is going to happen after.
Exactly.
And then I can't imagine, obviously, because they're preparing for the arrival of their baby. And then how, you mentioned surgery can be really quite soon after birth. How soon can they?
That can be in the first days of life.
Wow.
It really depends on how severe the disorder is. And honestly, what I did not know a year ago is that they also do it in utero surgery. Yes. Wow. It's really unbelievable. Yeah. So I had one child, and it was really amazing. And afterwards they have to have additional surgeries, but it's just trying to keep this heart going.
Yes.
And what I think is not in mind of many of us is that the difficulty already starts in utero, because the children's heart and brain is not as well oxygenated as it should be during a normal pregnancy.
Of course.
So that's the reason why they already have an altered brain development. So the myelinization is reduced, and also the perfusion and oxygenation is different. So it's very similar to the trajectory of infants being born preterm. Yeah. So they have white matter lesions.
Okay. And so, I mean, that's such a great rundown to be able to think about what that means and the age group. It sounds like it's always picked up as much as they can, as early as possible, so surgery can happen really early. What's the sort of, how much older do we get the kids who need open heart surgery, who've got congenital heart disease, who are 2 or 3 years of age? Do we tend to see that?
Yes, as well. It's like their disorders, they are univentricular and they need 3 surgeries.
I see.
And, they often have got as well as like cathedral interventions, and that can happen. So in our ward in the Children's Hospital, that can be until they're 10 years of age.
Wow,
and then you can imagine that there's a need to support them even more, because they need the physical fitness. And there comes along also another issue, that is, if you've got a child that is so vulnerable, you want to protect it. Every one of us would do that.
Of course,
So these children are not only being protected by their families, their parents, but also from teachers and therapists and doctors. Yes. So they are a bit, how do you call that? Their level of activity is too low for them. So they should be pushed in a way in order to even have better, heart function, lung function, muscle power, etc.
And how much can you push? I know as physios, often working with children, and we do monitor their heart rate, and we want to see if they're working hard and if it's going in the right direction when they're exercising. How much can you push? I mean, if a child who, say, has had surgery and they're recovering, would you expect that they could exercise in the same way as everyone else? Like, or are you guided by the surgeon? What happens there?
So I think you have to make sure that, of course, you're in contact with the
Absolutely.
cardiologist,
Yes.
and to tell you where to go to. But the infants or children, I saw they show you themselves when they are.
So they're self-limiting in a way. Yeah.
And I think as well what we as physios tend to do or have been doing for the last years is that we're just too nice to these poor infants and poor children. I don't mean that in a bad way.
I understand that.
But if you don't go out of the comfort zone, you can't train.
Yes,
so
that's right.
that's something what we do in every day. You know, if you want to run, you have to do more than once a month and things like this. So I think it's, you know, what evidence-based medicine say. It has to be fun, but also an active and you have to get a bit out of your comfort zone.
Yeah, sure. And that does mean that there'll be some discomfort, right? So,
of course.
You know, when you are exercising, depending on your different levels of fitness, sometimes it'll be harder, but it's knowing what those signs are and going, this feels a bit distressing, but I'm okay, versus this is a bit distressing, I'm not okay. I guess those signals will be something to learn.
Yeah. And parents are being told when they're discharged home.
Yes.
Is that about the color of the skin, you know, it's like it's very similar to children having respiratory difficulties, colors of the lips, sweating, and the heart rate.
Yes, yep.
And I can imagine for these parents who have, you know, watched their child go through a significant surgery, coming out, there's going to be that hypervigilance around, making sure they don't exert themselves too much. And so I guess that's why one of the many things I liked about what you went into is educating the parents so then they can feel empowered.
Exactly,
like you said, not push, but just maximise where their child can, you know, their recovery so that they can regain as much independence and function.
Yeah, that's right.
Exactly. It is, someone asked me, so if you want a child being in the prone, so what do you do when they start crying? And I said, first of all, we have to outwit gravity, so to make it easier for the child.
Yes.
And B, the parents is the one who has to be there in order to show me and the infant that's all fine, and as long as the parent is fine. And a little bit of, as you said, going out of your comfort zone, that's totally fine.
Yeah.
It's life, right?
Yep.
So that brings me to my next point. We talked a little bit about the impact of, I guess, even having a congenital heart disease being picked up prenatally and what that might be having on a child's, I guess, brain and cortical development. But does having a child with congenital heart disease mean they're more at risk of motor and cognitive delays?
Yes, indeed. So it has been shown that these children have neuromotor difficulties from infancy until adulthood. So apart from motor delay, which is picked up pretty soon, there's language difficulties and learning difficulties, behavior issues, and executive functions difficulties. But, you know, not in that severity as we know with children with CP, with a GMFCF level more than 3 or so, not generally. But it's like this difficulty in academic achievements, which is very similar to our preterm children.
Sure. And so are these children, after they've had these surgeries, are they screened for this, or do they undergo routine therapy, you know, to keep an eye on this?
The thing is that this is one of the reasons why I did my research. So I met my first promoter, Bea Lattel, and she's a neurodevelopmental pediatrician at the Children's Hospital. And she said she lost her heart for heart babies. So this is really a nice thing. And they control the infants after when they're 1 year of age. And when they're 6 months of age, 1 year of age, and then they have a follow-up with 2 and 6 years.
Yes.
So they started to do that from that point of view. And in the systematic review it showed that these infants do not get intervention that is specifically tailored to this infant compared to children who had been born at risk, like preterms, who get that on a standardized basis. So because the focus is so on the heart, and the infant group, of course, who are severely affected, like univentricular heart disease or infants with a syndrome like trisomy 21 with a heart defect, they are having physiotherapy anyway.
Yes,
but it's
of course.
this group which seems to be okay.
Yep.
You have got heart surgery. Yeah, you're doing a bit slower than the usual population, but that's fine.
Yeah.
It can be that they don't show any signs early, but later when they go to school, where you can see then the small difficulties, and their motor development is a bit, reduced. They're a bit hypertonic often, not always, of course.
Wow.
Yeah.
And you can just imagine, as you described that already, that once you've had, again, surgery is such a big thing, and once you survive the surgery, you want life to continue as normal, and because it's just such a big event. But then realising that there might be further challenges, just, I guess, puts into perspective what still might need to happen. So I suppose with your systematic review, I know you just mentioned it, you were really looking at some of the spaces of current therapeutic interventions. What were some of the other gaps? I know you sort of mentioned it wasn't really particularly tailored to this group. Was there anything else that you found in your systematic review that really took your attention?
What you just said, also that the parents are not involved as much as they should be. There's a talking of research for years, also family-centered care. This is nothing new.
Right.
But of course, somehow it doesn't come into the praxis as much as we want to.
Right.
So I don't know I think it might be different here in Australia. But there was one paper we included is from Susan Long, who is from Melbourne, and they had really difficulty implementing the intervention, but also because of the remote distances in Australia.
Yes.
So that was one of the so they had to stop it.
Yes.
But it's, I think many just did their program that they learned, like activating, doing respiratory therapy, doing passive movement, and that's it, what we learned to do as a PT.
Yeah, that's right. Well, things have moved along quite a way, but that's so great to have done the review of the literature and kind of go, okay, well, this is our baseline and how can we build from here?
Now, I know you conducted a qualitative study as well, which I think is obviously so important on parents' experiences. And there's a lot in that. But if you had to pick one, what would you say is one of the most important findings?
So I've got one sentence in my mind of a parent. She said, I wish that all these puzzles would be put together by someone so I don't have to explain myself to all the professionals again and again.
Oh.
And I wished that they take me seriously and ask about my expertise as a mum.
Wow.
So that was really, I'm still getting goosebumps when I think about it.
Wow.
Yeah.
And I think it's what we discussed as well on Monday is that there's so little we as therapists can do, and we have to put ourselves down on earth. It's the families and the parents.
Yes.
You have to have them on board. Otherwise,
But it's so important to have that mindset and to know that, because then, like you said, your recommendations that can come from that can only improve practice for the families, which at the end of the day is going to impact the child.
You have to ask what they want. Of course, in the light of your expertise.
Of course.
Because you cannot cover everything, because that's not our education.
No.
But you have to ask them and relate it. And I think what I really like a lot is that we have so great skills in our profession.
Yeah.
And we can use that to promote family well-being and attachment with the parent and the infants. I think this is
so important.
Yeah.
I think it comes back down to what you just said about family-centred practice. I think for a lot of clinicians, we've been training this for a long time now, and it might seem really natural and that's the way we should do it, but it hasn't exactly seeped into other professions either. In some of the medical areas, family-centred practice, sometimes there's not enough time to say that we do family-centred practice. And the story that you just said before about that mum's experience of having to constantly re-explain what's been happening, that is devastating for a family to have to go through, isn't it? And the systems need to come around to support them more, because that's absolutely exhausting. But that's also family-centred practice. It's actually meeting them when they need to be. And it's a really important reminder for us as clinicians.
I think it is, might also be painful for yourself that you have to accept that's not you.
Yes.
Yeah.
And it doesn't matter which discipline.
Yeah, that's right. Yeah. So early intervention now then, what does it look like for this group of children given, I know we spoke a bit about it briefly before and, trying to push a little bit out of their comfort zones, but what does it look like when you enter a room and you want to provide that support for a family?
So we started intervention after hospital discharge in the thesis, or let's say in these studies.
Yeah.
So it was quite interesting what we tried to do, because it was also Corona time then. We did the sessions were done at home, in the hospital and online. And this is something which we didn't do in Europe before that.
Yeah, of course.
I know that you did it more because of the distances in Australia, but this is something. So the first meeting I went home, which was very interesting for me, because then you see what's important and what's not.
Absolutely,
to see. Yeah. And asking the parents what they would like to do. Yeah. Yeah. Focus, of course, on things we can have an influence on, hopefully. Sure. Yeah. And what I realized is many of these parents are afraid to sit their infant. So, and we know from learning, motor learning theories, and also from practice, that the more you put an infant or child against gravity, the more muscle fibers are being recruited. Yes. But still, many therapists leave their infants on the floor in supine. So what one of the situations was, or many situations, is how can we get this infant? They were between the age of 3.5 months until 5 when I started. Yes. Into a sitting position where they're active. It's not. I'm not talking about sitting them passively on the floor, like collapse. But sitting with a little bit support as much as they needed in order to be active, hold their head and control, and get into action. Moving their hands, looking around, interacting with the mum. Yes. So what I tried to do is a situation where we were at eye level. Yes. And there I was very inspired by the work of Duising, of the group in in America, where they really tried, in the USA where they really tried to support cognitive learning. Yes. Eye level with functional tasks, looking at a book, hearing, singing together, having things in the hands. So you have the hands in front of the face and you see what you're doing. Yes. And with that, promoting postural control.
I mean, that sounds so familiar to
us,
right?
Of course.
It's
nothing new.
Yeah. And it's trying to get the child to be active and engaged, because I think that reflects, because it reflects how children learn and be engaged and motivated.
And
So when you have them in that sort of sitting position, we are saying that this is very possible for these children to do. The reason why they're in supine is mainly out of fear or not sure what to do,
It is one of the things we had a baseline variable where we took the motor optimality score of the general movement. At fidgety age. Yep. And almost all of the infants we included, they had atypical postural patterns. Okay. In supine, because you look at them in supine, like they were arms stretched out, the legs, and so what I was missing to see is all the interaction coming towards midline. Yes, which is what we also saw, like indicator for reduced muscle tone, low tone. Yeah. And this is one thing. So we have got the low muscle tone, which is often present, but also the surgery itself. Of course. So I sat together with the surgeons because I wanted to know how that looks like and what it means. And they spent hours with an open chest. Right. So we included children with stenotomy. I didn't say that before. So that because that is then you have can you imagine that the chest is being pulled apart, and you can even see that. You can see that, and they are really in a hyperextension of the thoracic spine, and then of course all the rest. Yeah, you can't bring your hands together. Exactly. It's so much more work to do that. And then the scar. So parents are afraid to put them there, but it might cause pain. Yeah. Prone, it's an uncomfortable position. Infants start crying. So what do you do as a parent? You just flip them.
Alleviate it. That's sure.
Because
Okay.
it's challenging them, obviously, physically for them to lift their head up. But if they've already, like you said, got that apprehension, the pain, how long after, say, open heart surgery, is there a certain period of time when children can't be placed to prone, or is it just once the scar heals and they can tolerate it?
The thing is that in intensive care unit, they say it's not allowed for 24 hours.
Okay.
Just to place them
really
very
short.
It's very short.
Yeah, wow.
But for parents then to put them and be comfortably handling them, they say 2, 3, 4 weeks. It's like 3-4 weeks.
But still, it's not long.
No, it's not long.
Yeah.
And I talked to the surgeon and he said, it should be fixed so well that it should not be a problem. And if it is a problem, then it's our fault.
Right. Okay.
So there's this fear all over the place.
Right.
Yeah.
And of course, what we can do is we can counteract gravity, so make it easier for the infant, not being flat.
Yes, of course.
And I think taking away the fear of that already helps parents to see that they can do that.
Yeah.
Yes. Because I imagine without going on to prone, when we start thinking about development, and you talking about kids who, are just getting up to sitting, so that, is engaging from an upright position, is against gravity. So you're kind of taking care of a few things that you'll be doing in prone once they're a little bit older. What about the phases of crawling and moving through those phases? Do these kids tend to skip that phase of crawling and get up onto their feet because they don't want to be prone in that sort of position? Or do you recommend they go through the whole phase? What happens?
It's interesting because in my qualitative study, most of the infants were bottom shufflers. So that I thought, that's really interesting.
Okay.
And then parents told me, yes, she wasn't comfortable.
Somebody,
But having said that, of course, not all do bottom shuffle.
Sure. Yeah.
And in the study, all infants, in the end, they crawled a bit, but it was not the aim for the infant to crawl because
they wanted the mobility.
Exactly. They did it themselves. But, like changing and introducing situations, like even though when you're sitting and leaning against the sofa. So I really liked it, having a child on the corner of the sofa and putting it there. And if they fall to the side, so what?
Yes.
They roll on the tummy.
Yeah. So it's all very active.
It's
really
active
moving away from
and it's
handling.
the transitions, which I didn't aim anything for crawling. It was the transitions I was trying to kick and teach the parents that if they fall, nothing is going to happen. There are pillows, it's soft.
Sure.
And then the infants are, of course, they're like scared a bit, and parents as well. But nothing happens. And this is where I wanted to give them confidence and just tell them, hey, look, they're doing it fine. It's all fine.
That's how they learn. They have those opportunities in a safe and supported way.
Yeah.
Yes, and then we use evidence practice, what you asked me before. It's like, having fun, being active, doing it yourself. Otherwise, you don't learn.
Yes, absolutely. And we know that, don't we? Like when we're hand over hand or we're facilitating all of the movement, we're doing far less than we think we are. I think that's the thing, isn't it?
It's that us doing a lot doesn't mean that they don't. They do less.
That's right. And I think it's when you go back to, a lot of this comes back down to a lot of the work that Professor Anna Novak and her group have done. And when she was on the podcast, she said, whose brain is doing the work? Is it the therapist or the child?
Exactly.
And we're not just talking about children with cerebral palsy there. We're thinking about everyone as they're learning how to do something. I don't learn how to drive a car because you do everything for me. Your brain's working, I'm not. But it's the same principles here is what I'm gathering for this group of children. It's no different.
Yes, and it's the same for, as you said, for us, for the parents.
Yeah,
allowing them to, so there's sometimes situation where the parents and we're observing the infant and the parents want to help, and I just try. Yes, wait, please. I'm sure you know that. Let's wait. And it has been shown that the family factors are the most important outcomes in infants with CHD.
Right, okay.
More important than the surgery itself.
Right.
So that's the importance why empowering families and having them on board is, I think, one of the most important issues.
So I guess my sort of take on that is if a family comes to you and you're a therapist and they sort of hand their child over to you, help me, we really need to make sure that we might start that way, but we've transitioned back to them as much as we can to empower them. rather than have it to be dependent on us as therapists, really.
Exactly, and then it comes about intensity, right?
And that intensity of practice.
Exactly.
And empowering them and giving them. That's what I loved so much about your paper. It kind of brought so many things together.
Yeah.
And even from other podcasts we've done with other, healthcare professionals in, as psychologists or other areas, and about, the importance of attachment and, I guess, parents' mental health and well-being and how that impacts a child. And your approach kind of looks at all of that combined with our role as physios, which is obviously fundamentally to improve those physical skills. But particularly it seems like in these children with congenital heart disease, obviously that fear and avoidance and protection that parents want to provide is a big thing. So in what you can provide by educating them around, things to do is amazing.
And I also talked to psychologists, and they said, Elena, they might not want to talk about their problems, the parents. Yeah. And it's like a grieving process. Yeah. So you cannot just talk and everything is fine. So what their wish often is is to look for their infant and how they can improve, how they can support it, and then help it. Because we had one symposium in Switzerland, and the parents said it took them ages, even years, to understand that what it means to them. So it's like you cannot just have it's not the only way. There are many ways.
Yes. Yeah. So given this journey that you've been on in working with families and applying what we know and the evidence that is in other clinical populations into this population that you're working with, what would your advice be to other clinicians who might be encountering a population of kids that don't have a lot of literature that's already published on them? I'm often thinking about kids with rare diseases or, things that you don't see often, and there's not a specific paper on that particular population. From your journey, what would your advice be to those clinicians?
I would advise that independent of the age of the child and of how many children parents have, you have to acknowledge that they are the experts of their infants. They know them best. Doesn't matter how old the child is, because they have a journey we would never, we don't know, we haven't experienced. Yeah. And you have to acknowledge that they are the experts of the infants, and that you partner with them, that you have an equal level, and they're the experts in their child and infant's care, and we are the experts in motor development, and then try to find where that comes together and where it fits, and where we can go together with. So not looking above down to someone. Yes. And also, so what I really like to do is, like when I do something when I have therapy with a child, that I tell them what I try to do and don't know if it works. So I'm just seeing that this infant really enjoys looking at us, and then we'll try things out, how to make it even more difficult for a child. Yes. Yeah. And then the parents give me their advice, how they could do it at home. I've seen so many cool ideas, how to promote early sitting. Yeah. So I went home, and mom said, I've got an idea, and she put her infant in a trip trap, do you know this? And put it in front of a piano, and the child was starting, it was 4 months old, and I thought, I cannot believe
support there.
Yeah, exactly. So you've got, a mom sending me a video, because with details they sent me clips they did of the infant being in a small bathing tube. Yeah. We just sat in and she read a book to it, and I was like, I didn't tell them to do that. Yeah. So they did it themselves.
They've taken your ideas.
Exactly. And many things of that. It was really fun.
And I love that. And I think, Elena, what that reflects to me is, because you're listening to the family, you understand what it is that they want, where they're at, meet them where they're at. Don't give them information they might not be ready for yet, go on the journey with them. But it's very much that you've taught them what motor learning actually is. What are the principles? Because forget about the names of what therapies might be called. I think there's brands that are out there. They'll say, we do this, we do this. Let's get rid of those names, and let's say, actually, motor learning is active. Find opportunities for your child to be engaged and self-initiate the movements and practice it frequently and make it a task-specific so it's relevant for their age. If you give parents those tools and say, this is what you need to do, because we know it's proven, regardless of populations, transdiagnostic, you're doing everything perfectly fine. And that empowers people to come up with those scenarios. Otherwise, it's like, oh no, what do I need to do next? What's the formula to do this and that?
Exactly.
Yeah.
And I found that they sent me video clips showing me things, and I really empowered them. That it's really great. And could you also try maybe this out?
Yeah.
And it's like giving them suggestions, and also taking suggestions, and also I think something showing that there's so many things you don't know. Either. And then you say, okay, I have to ask because I have no idea about this. So showing that you don't know that, I think this is a step how
doing
you can
that journey together. Yeah.
How you can do this journey together, yes.
Yeah. And I guess that telehealth setting as well probably facilitates that. I feel like at the moment we're interviewing a lot of researchers whose research was done during that period. I think we're getting all the results now, but being able to do telehealth well is a great tool for us to use.
So I was at the beginning, I was a bit, cautious about this thought because it's
different.
Yes, and you're so far away, and you can. Right. But I loved it. We did 1/3 of the therapy intervention. We did it like that, and I loved it, and it was so fun because suddenly there was, for example, a dad who ran away because I've got an idea, so he ran down the cellar, got of the pram where the babies when they're very small when they're lying. I got that. I will sit her in there, and he's stationed there. And I thought, wow, that's great. I didn't even think about that, you know? So it was really fun, and it made you give this space to parents. I think this is what...
Yeah. And that's, for me, I call it the MacGyver moment. If you're old enough to know what MacGyver is.
Yes,
you know what MacGyver is, Marissa?
Yes, I do.
You do, thank goodness. Yes. So MacGyver, for the younger people who don't know what MacGyver is, I don't even know really who he was in the end, but he basically would problem solve. He needs to get out of a room, like an escape room kind of thing. Is that relevant for this age? And they want to get out and they look for all the different tools that are around, and he makes stuff. But it's about using what you have.
Exactly.
I guess is the point.
Yeah,
and
exactly.
You don't need anything fancy sometimes. Yeah, I think that's really cool.
So I love what you've done, and I'm so inspired by it. And I love that we can apply it to other, like Dana said, other disciplines and other, groups within paediatric care. Where to from here for you, and what other ideas do you have in mind?
So we have now the foundation for a bigger trial, I suppose.
Great. Yes.
So I would really love to. We don't know the finances yet, but the idea is to do a bigger trial, and we learned a lot. In the trial, we learned that we had far too restrictive inclusion criteria. We learned that not all the assessments we used were helpful. Okay. We learned that maybe we have to start earlier.
Yes.
Like to use telehealth, for example, as a bridge from the children, from the hospital to home, where you're in a hospital where you're supported and, surrounded by so many health professionals, and suddenly you're at home and you're alone. This was also one of the findings of the qualitative studies, that it was so hard suddenly to be at home.
Yes, of course.
And having to do all these tasks by yourself. The medication, because they have to use medication, and also a big issue is feeding,
Of course. Yeah.
Many of them have nasal tubes, etc. And so maybe using telehealth and start earlier to do this bridge and already support them from the beginning so they don't have the feeling of being lost. But of course, we have to ask the parents if they want that. Because we often have this, so we can do it like this or this. Yeah.
I love that. Well, I guess that's the whole idea of research. It keeps building on each other, and we ask bigger questions. And yes, you should need to find a grant to help you to do that. But, that's the point, is to engage with all these stakeholders. So look, this was an incredible conversation, and I hope everyone really enjoyed listening to that. But guess what? We're not done just yet. Of course, we have our next segment where we bring it all together, and it's called Tell It to Ed. Ed, as you know, is our producer. He doesn't have a background in child health, but he has been listening, and he has probably been taking notes, and he usually has a good question for you. So, Elena, before Ed has an opportunity to ask you a question, I'll get you to summarise this area of research that you've been doing in about 60 seconds. And Ed, you'll have time for one question. Take it away.
That's fine. Knowing that infants with congenital heart disease are an overstressed and underserved population, we should start and help them. And they need, from the parent side of view, support in development, and also to promote parents' well-being and attachment with infants, and we can do that as physiotherapists because we've got all tools to that, as long as we stay equal and partner with the parents.
Love that. That was a good summary.
Very good.
Yeah, I love that. Well done. All right, Ed, over to you.
I've loved the conversation today. I keep saying that about every episode.
Saying that, but that means they're great conversations.
It's always really good to listen in on this. And I think you've covered quite a lot of the ground that maybe I might have asked some questions on. And I think the family-centred care part and then just kind of going back to touching on the study being completed during COVID-19 and given the conversation about, hands-off therapies and that sort of thing, I'm curious as to whether the concept of all of the telehealth and the remote kind of access and encouraging people to do these sorts of things themselves and becoming more inventive had any kind of impact on the perception of hands-on therapy versus hands-off therapy and how that kind of correlates to what we kind of know about evidence-based practice now. So I'm just curious as to how COVID kind of impacted on that.
I think it helped. Going back to COVID, yes, it showed. It showed that you have to be patient and wait and don't get active so fast as a therapist.
Yeah.
Because I like to do that, but I realized that I have to wait and count silently. So
true.
this is one of my helps is that I always count until 12 before I start to doing something.
Yeah.
So I said 21, 22, 23. Because they need time
Yeah. And I love how you said that. And that was a really good question, Ed, because sometimes people think that it's really dichotomous. It's just like hands-on or hands-off. And I think we've had to swing really hard to say it's hands-off just to get the idea in our head to not always have our hands on kids. The reality is we need to be headed towards that direction where they're doing most of it themselves. But facilitating that process sometimes means nurturing, being close by, but as much as you can, letting them respond and not taking over, which is the point of the counting, isn't it? Don't take over. This is how you do it. Let me show you.
Exactly. Go out of your comfort zone. Do it yourself.
Yeah, it's so true. We're asking that of our families. It's important for us too. Like, it's out of our comfort zone.
Exactly.
Because waiting for 12, 20 seconds feels like a long time sometimes.
Yeah, it's a long time.
Right?
But that's often when the magic happens, we say, like you give them that time. And when you as a therapist might restrain yourself to jump in and just do it.
Yes.
It allows them to be able to do something actively.
Yeah.
Yes, it was really interesting. I videoed all sessions online, at your hospital and at home. So we took recordings.
Yep.
And then we changed it with the parents. So we looked at it together and then I also said, I was too fast. Did you see that? I should not have jumped in.
I like that.
Self-reflection and therapy.
Yeah.
Because then they can see, okay, she's not knowing all the time the best, and I'm not. Of course, I'm not.
Yep.
And that I really like. It's feedback and also allowing that you make mistakes and learn like infants and parents too.
I love it. Good question, Ed. Thank you very much.
Thank you.
All right. Well, that does conclude the podcast today. Thank you so much for coming in today, for taking the time to come to the studio whilst you're on holiday here in Australia. We've really enjoyed the conversation. To all our listeners, I'll put links for these papers that Elena has already published. I think there's still more to come. Yes. Well, head to our website, researchworks.net. And of course, there's a CPD form there that you can fill out as well if you want to keep this as part of a record of your PD requirements. But for now, it must be acknowledged. Thank you for doing this podcast in English, which I know is not your native tongue, and it's incredible. Amazing. I always find that amazing.
Thank you for inviting me.
It's so lovely. So to all our listeners, we'll talk to you all again next time. Bye.
Bye.
Bye.